I'm sharing the screen. Can you see the first slide? So I'm going to talk to you today about nanotechnology in the foot and ankle, or needle arthroscopy, as it was previously known. And it's been around for several years. But recently, this company has brought out, and I have no disclosures or no financial disclosures that are relevant to this, but this company has brought out a new device. And the device is interesting because it has an ergonomically designed handle. It's very, very light, and it's very, very small. It's only 1.9 millimeters in diameter. And the reason it can be so small is because they now have a chip-on-tip technology. So the old fiber optics are out, and this chip-on-tip technology is in. And what that does is it provides us with really terrific imaging. This picture here obviously is of the knee, but you can see the meniscus and the femoral condyle with greater clarity with a smaller device than you can with the original 4 millimeter device. So the reason that's important, well, there's many, many reasons why we think it's important. In this very nice study that was done by the late, great Paul Galano, he showed that overall there's over 30% of patients who have an ankle scope will have some form of iatrogenic articular cartilage injury. That's a massive amount. 1 in 3 will have some form of cartilage injury, but only 6 or 7% of those are severe. So we think, well, that's not too bad. The problem is, when we look at some work that we collaborate on with Larry Benasser, the first 500 microns of cartilage are responsible for 90% of joint dissipation of compressive loading. So that means even in those cases that have a small amount of damage, that's very significant downstream because we know cartilage can't repair itself. So that old maximum, first do no harm, and I think these smaller scopes allow us to see and do things without causing this iatrogenic injury. But of course, that's not the only reason. There are many reasons, and we alluded to those earlier on. One of them is that there's just a growing fund of knowledge looking at what's going on around the foot and ankle, particularly not just in cartilage, but in ligaments and in tendons and all sorts of structures around there. And these are structures that are amenable to minimally invasive procedures. So the advent of this new arthroscopy device is certainly pertinent and relevant to what we're finding. So this is what we use. It's a very simple device. It's a throwaway at this point. And this is the kit that we use in NYU. You can see the kit down on the left. It's very, very small. We also just have biters, and we have scissors and graspers, and then we just have a very, very small dressing set for afterwards. So it's a very small set. It doesn't take up a lot of room in a surgery center or anything else like that. So this is the nano instrumentation. It's only 2 millimeters diameter at the tip, so I was a little bit worried about it. So one of our clever residents said, well, let's see how strong it is. And as these were disposable, he cut the electrical cord going to the nano after the procedure, luckily. And you can see that there's nothing really in the ankle that's going to be much stronger than that electrical cord. So it's done it shows that it's very strong. Now, there's new stuff coming online, and what we have, typically I like to do a lot of work on osteochondral lesions. So these are new devices. We have awls, there are different angles, but of course, this is a straight scope. It has 120-degree field of vision, or like a fisheye. So you'd like to be able to get around a curve with some of your instruments. And so we actually have come out with a new device now that will be able to bend those, and so you'll be able to get to where you need to use a curette, an elevator. We're using pediatric osteochondral lesions, and even when we need to do small, limited microfracture with these awls. We're also using these burrs. Right now I use a 2 millimeter burr, and it's typically enough, but sometimes when you have large anteromedial impingement lesions, you need something a little bit more robust, and so that's coming out shortly. And we're also bringing out a power pick, which will be a little bit more controlled in terms of microfracture. The nanosuction biter was developed by some of the hand surgeons, and I think it's a very nice tool, not only in terms of the foot and ankle, but also in the knee to do many meniscectomies with this. So this is what we're really talking about, the ability to see, and not only the ability to see, but the ability to do in the operating room or in your surgery center or in bedside. So MRI is here to stay. We're not going to try and supplant that, but what we want to do is improve on the sensitivity of MRI, So I like to see osteochondral lesions, and that can determine the quality of the cartilage that's there. I can also look at impingement, both soft tissue and bony, as a dynamic study. We can look at subtle syndesmotic instability. We can look at ankle fracture reduction, and also pain of unknown origin, which we often encounter. The things that we can do are just as important. So any loose bodies, synovitis, osteophytes, anterior impingement, and even osteochondral lesions that are smaller than 10 millimeters, we can address at bedside now. And we've just been working on inside-in technique for ATFL repair. So how do you do it? It's exactly the same setup as if you were going to do this in the operating room. You identify your landmarks, you identify the SPN before you do anything, and I just insufflate about 10 minutes beforehand with lidocaine and marcaine into the portals and into the joint. And we put a little bit of epi into that to prevent any bleeding. We don't use tourniquets at all. And then we do the same thing, nip and spread technique into the portals, and then we advance our medial side first and then our lateral side. We put the pump at relatively low flow, 35 millimeters, and then we can do that, as I said, in the operating room or in your bedside here. This is what we do in NYU. We were the first, I think, certainly in the Northeast, and I would hasten to say, or possibly in the world, to do this. And you can see it's very, very easy. The patient there is looking. You can see this pre-COVID. There's no mask, but he's looking at what's going on within his ankle and quite content to do so. So I'm going to go through, I think a couple of cases are always more interesting than just talking about the device itself. And of course, the first person to have this done was a very dubious character, a balding, middle-aged male, ex-rugby player, who had multiple knee traumas. And this is what Dr. Schoen found inside his ankle. This is severe degenerative changes. So this is a harbinger of poorer things to come for this poor fellow, but at least he knows, and it can address that with biologics before he gets an arthroplasty. So the second case was a 65-year-old female. She had pain over the anterior aspect of the ankle. She had limited dorsiflexion, and it exacerbated pain. And nobody could find anything, and she came to us as a last hope. This was her MRI, and it wasn't very remarkable. There was nothing there that we could really identify other than a little bit of cicatrization of the anterior aspect of her joint. So we put the scope in, and the very first thing that we saw was this bony exostosis, or loose body, indeed, as it become, at the front of her ankle joint. That was moving around, causing all this inflammation and pain when she dorsiflexed. And once we removed it, and then she was much better. In fact, she walked right out. And within a week or so, she was very, very happy. So 40-year-old male, status post Oates procedure of the talus 5 years ago, and now he has pain at the anterior aspect of the ankle joint. And we find this a lot with those who have a medial malleolar osteotomy. About 5 to 10 years after surgery, they come back with a little bit of anteromedial impingement. This didn't seem too bad. We didn't do an AMI view on this, but you can see there's a little bony protuberance and mostly soft tissue. So we did an in-office procedure. This is when we go in. You can see a lot of fronding, synovial hyperplasia, and a lot of scar tissue. This is the trio resector we're using right here, and it's very effective for removing this. And the patient has no pain whatsoever. He's looking at this all the time. This is on the lateral side. He's a hypertrophic AITFL. We use the biter to get rid of the anterior band of that. And now we're just advancing in to look at his old Oates graft, which you can see there's a little bit of fibrillation, but on probing, it's quite stable still. The next case is a 33-year-old male, and he had multiple lateral ankle ligament surgeries, and now he had pain over the subtalar joint and peroneal tendons. And again, it was a little bit of a last gasp for him, and nobody really could come up with what was going on, and neither could we. This is his MRI, which shows there's a massive scar tissue over the lateral aspect. You can see multiple previous surgeries have been performed here, but nothing that necessarily hits you as a primary diagnosis or primary pathology here as to why this young guy can't run. Again, we said, well, the best thing to do is to have a look. Not only can we have a look, but hopefully we can also address what's going on here. Now, what you're looking at is the peroneal tendon. That's the peroneus brevis. We have this little hook behind the CFL in the subtalar joint, and you can see all this scar tissue. It caused him some stenosis of the peroneus brevis. And once that was removed, then he got back, and he's now an active member of the FBI. Next case is an interesting case, a 23-year-old female. And just the other day, she posted online a very nice picture of all of us. She's very happy with her procedure because of this. She'd spent years and years not been able to do the things that she wanted to do because she had a Salter Harris type 2 growth plate fracture as a teenage gymnast. Since that time, she had multiple surgeries to address her deltoid, her posterior tibial tendon, and none were successful. And so we didn't know whether we could help her an awful lot, but we do have an ultrasound in the office, and this is what we're able to find. And you can see on the right side of the screen is normal pathology for the posterior tibial tendon, and it's in this shallow groove. By contradistinction, when you look on the affected side, you can see that there's an overgrowth, most possibly by that zone of Ranvier that Shapiro talks about in and around the growth plate, and it's created this hypertrophic scarring and hypertrophic bony protuberance. And her posterior tibial tendon was becoming inflamed in there. So what we did, we brought her to our treatment room, and you can see there's her posterior tibial tendon, and we're now shaving away that bony protuberance. And we're getting through the periosteum first of all, and we shaved it away, and she was happy for the first time in many, many years. So something that's relatively difficult to diagnose, but relatively easy to treat. Certainly the nanoscope can give us that ability. This is a 34-year-old male with recalcitrant non-insertional Achilles tendinopathy. He'd failed shockwave, and we brought him to the operating room. And you can see this massive amount of scar tissue between the paratenon and the tendon itself. We know that the paratenon contributes to a lot of the inflammatory pain that these people get, as does the plantaris on the medial side. And we resected both. So in other words, we debride all around the tendon and resect a little segment of the plantaris, and this chap got back to doing his normal activities. This is an interesting case, 63-year-old female. She had a hydrogel implant in her first MP joint for end-stage hallux rigidus, but she had persistent pain. And we can see that 1 month post-operatively, that the hydrogel implant is not looking terrible, but at 5 months, it's really looking as close to catastrophic as you can get, because now it's created counter surface wear, it's loose, and so she didn't want a fusion, so we wanted to have a look at this. So this again was done in the office. So you're looking at her first MP joint, and we're just shaving up some of this. But you can see the gross destruction of the joint itself, and you'll see just in here is a polyvinyl insert, and then you're going to see how it's now almost countersunk where it should be proud, and the damage that it's done on the phalangeal counter surface. This is an interesting chap. He's a triathlete. He did 7 triathlons in 7 continents in 7 days. He's also an investment banker, so he can afford his own plane to fly to these places. But he came into us with this osteochondral defect a few years ago. And so we tried biocartilage. Now, biocartilage, as Dr. Shimizono talked about, is an extracellular matrix. We use it as a scaffold in osteochondral defects, and then we seed that with concentrated bone marrow aspirate, which has stem cells and growth factors. And it creates this secretome, or this biological milieu in the area, which promotes cartilage. And that's the theory. But it didn't work very well, and this is because it came back with pain. And this is a second look nanoscope, again in the office, looking at the biocartilage. And you can see it's fibrillated and it's degraded. And so this is just a couple of years afterwards, and it really hasn't done well. And he subsequently went on to he required an Oates graft. But again, MRI didn't pick this up. MRI said there was substantial infill, and so MRI is very, very useful, but certainly Nano can fine-tune what we're looking at. This is a 23-year-old female. She had an ostragonum resection, and then she came into us with persistent ankle pain, the posterior aspect of her ankle joint. And this, again, you can see the setup in the office. Very, very simple. We do a posterior scope with the patient in a prone position. And this is what we found. Once we got in there, you can see this big glob of scar tissue right there at the subtalar joint and ankle joint. And there's her FHL running right adjacent to it. And you can see that has become scarred and stenosed at the back there. So we clear everything out there very carefully because obviously a little bit anterior and medial to that is the neurovascular bundle. And we'll be able to see that the passage of the FHL is now clear. We go down in and around the medial mal just to see how clear it is, and it looks absolutely normal down there. And again, all of this is done in the office showing the patient. This is another patient, 42-year-old male or female. She came in with MTP joint pain after a marathon, and everything looked normal on MRI, everything looked normal on X-ray, and this is what we found. We put the scope in, and you can see she has a very large chondral defect in there. We're able to put in a 3-millimeter shaver, and this is the chondral defect. You can see that's where it came from. So again, there's not an awful lot you can do to prolong the life of this joint. This is a joint in danger, but certainly it's a very useful thing to be able to give at least the patient a prognosis that's more realistic. This is a chronic insertional or Haglund's deformity, and again, we can use this in the office setting to resect them. For some reason, this video is not working, but again, we do the same thing for a posterior portal, and we're able to take away that Haglund's and debride the tendon where necessary. And we wanted to look into the sesamoid. Sesamoid for me is a joint that I don't love because it's difficult to know what's going on in there. So we brought it to the lab, and we're very lucky in NYU to have a terrific lab that we can identify and work ahead of things so we can see what we're doing. So this on the left is the lab, and on the right is actually the sesamoid when we actually got in to the joint itself. And you can see that it's maltracking, and it's just like the patellofemoral joint, and that the patient had chondromalacia here, and we're able to deal with that by injecting a biologic. And the patient, so far, they're about 3 or 4 weeks out now, seems to be doing reasonably well. So I know we don't have an awful lot of time, so we'll summarize. Needle arthroscopy can facilitate the diagnosis of intra-articular pathology in a simple bedside procedure under local anesthetic. The simplicity of the procedure allows the patient to observe their own conditions, and I think that's one of the most important things about this. One of our residents at the moment, Dr. Colasanti, is calling our patients, and the feedback that we're getting from anteromedial impingement patients is that they love to see what's going on in there because they can buy into their recovery a lot better than if I come out and tell them after anesthesia what I've done, because they can truly see it and understand how they can grade their own, or how they can titrate their own rehab based on what they've seen. So not only do we have the ability to see, obviously we have the ability to do a lot of things also now with different shavers, biters, graspers, etc. And I think a whole different talk will be on the biological augments and that we can deliver in a precise fashion to this area of interest. So I won't delay any longer, and I will hand it back to Lou. Will ask questions on this as I try and navigate my way out of the screensaver.
Great talk, John. John, the question that some people might ask is will this supplant intraoperative proper arthroscopy? I mean, we're doing it in the office. Now, will this technique supplant it, or is it just going to be a kind of more minor procedure on the way to the more formal arthroscopy?
It's a great question, and I think it'll do both. So I think many patients just don't have time and the energy to wait around for a diagnosis on things. And so we're not trying to take away from our MRI colleagues at all. I think there are many patients that come in that have been to several other doctors. They have many MRIs, and none of it's giving the information that we need. And in those cases, this is a very good diagnostic tool. In certain cases, not only is it diagnostic, but we can also do things in there for small osteochondral defects, certainly for things that we're just taking away stuff, like an os trigonum, like anteromedial and anterolateral impingement. It's really excellent for that because there's no downtime to that. The patient has it done, they get off the table and they walk home. For larger lesions, either from osteochondral lesions or for larger degenerative tears and so forth, then I think we need better visualization and distraction so we can get in at the back of the joint properly. So I don't think it's going to supplant everything we're doing in an operating room with larger equipment, but I think it will augment it, and I think it'll just enhance the whole field of arthroscopic visualization, because large caliber scopes just aren't very effective at looking into small tendon spaces. So we're able to look now into perineal tendons, into posterior tibial tendons, Achilles, and so forth. So tomorrow I'll be looking into a joint of a lady who has a plantar plate injury of the second MP joint. And we're going to be able to go in there. We're going to be able to debride the plantar surface of the proximal phalanx with a nanoscope and see that concentrated bone marrow aspirate to allow it to heal without creating an incision, and or without creating a large incision on it. So I think for those things, the world there's so much more that we can do with this. I think we're just at the very beginning of it.
Yeah. John, I've been very impressed with it because it's a flexible scope. I was actually able to go posterior to the tibial plafond, going back almost to the back of the ankle joint without even using just any traction other than just manual distraction. I got in with a nanoscope and saw beautifully what I couldn't see with a rigid scope. So I think there's you showed some great cases. There's a lot of indications here. Perhaps we could cut to the chase with our imaging and maybe offer people not only a better image of what they have, but also get them on the road to treatment in one office visit, as opposed to coming back with an MRI and then scheduling a bigger surgery. So hats off for you for innovating in this space, and hopefully our patients all continue to benefit from its use in the office and in the OR.